Hello guys, this is Vikrant and Sengar, pursuing MBBS from GRMC Gwalior, now presenting a beautiful lecture on a great topic, that is the Gastro-Esophageal Reflux Disease Part 2. So let's get started. So now guys, we will go for the Part 2 of GERD. We have covered the Part 1 of the same, and we have covered the anatomy and the physiology of esophagus and the risk factors, etiopathogenesis, clinical features and the complications of GERD. And today we will go for the diagnosis and the management of the same, and we will go for the endoscopy procedure, pH monitoring and the manometry for the diagnosis, and we will go for the lifestyle modification and the drug classification and the drugs for the GERD for the management of the same, and we will go for the surgery such as the fundoplication, and we will discuss the indications, types and the complications of fundoplication in this session. So let's get started here. So now guys, we will go for the diagnosis of GERD. Number one thing is the endoscopy, right? The upper GI endoscopy is done first, and the findings include the inflamed and hyperemic mucosa. And when we find the red, velvety, salmon pink colored tongues and the patches, that is basically the Barrett's esophagus, the complications of chronic cases of GERD, right? So that is basically the differential diagnosis here. And when the patient of heartburn is presented to the OPD frequently, and then we will go for the 24-hour ambulatory esophageal pH monitoring. So for this, we need to place a probe, right? We need to place a probe 5 cm proximal to the gastro-esophageal junction, right? So this is what the probe placement, and then we will go for the measurement of acidity. And if the pH of esophagus is less than 4 for more than 4% time period out of 24 hours, that is the diagnostic value, right? And second thing is the Demester's score. And if the score is less than 14.7, that is normal value, and if the score is more than 14.7, that is a diagnostic for GERD. And followed by the Bravo 24, that is the wireless probe placement method. So third modality is the esophageal manometry, and when the pressure of LES is less than 6 mmHg, that is basically a diagnostic for the GERD here. Okay, so that is causing the reflux and thereby causing the GERD, and this is what the diagnosis of GERD. Now we will go for the management of the same, right? So first thing that we prescribe to the patient is the lifestyle changes and lifestyle modifications, and we need to avoid those foodstuffs causing the reflux, and we have discussed the foods and the drugs causing the reflux. We need to avoid these things, right? Followed by, we need to avoid the smoking and the alcoholism, and the patient needs to take the small meal frequently in a day, and the meals are to be taken 2 hours before going to the bed, right? So this is what the lifestyle modification that we are just prescribing to the patient, and now we will go for the medications which are to be given to the patient here. So first we will discuss the drug classification. We have 5 categories of drugs. Number one is the PPIs, right? So omeprazole, esomeprazole, pantoprazole are there, right? And the H2 blockers, right? So histamine antagonists are there, such as the cimetidine and ranitidine are there here. And third thing is the prokinetics, okay, such as the metoclopramide, mosapride and etopride is there, right? So all these 3 drugs are causing the blockage of 5-HT3 receptor, and that is causing the stimulation of 5-HT4 receptor, and only metoclopramide and the etopride are just causing the blockade of D2 receptors here, right? And that is what the mechanism of prokinetics, and followed by the antacids such as the magalrate and sodium bicarbonate is there, and followed by the alginate coat is there. And we have discussed the mechanism of the prokinetics, and now the effects, the pharmacological actions produced by prokinetics include the increase in the tone of LES, right? And there is the increase in the clearance of esophagus, so reflux is not there, and there is increase in the gastric emptying, so that the reflux is not being so evident. Okay, so this is what the pharmacological actions of prokinetics, right? And the uses of prokinetics include the gastroesophageal reflux, the vomiting, that is basically anti-emetic, and followed by that is the gastrokinetic. So gastrokinetic is there, that is increasing the gastric emptying, thereby that is useful in the diabetic gastroparesis and emergency general anesthesia, right? So this is what the uses, and the side effects include loose stools, abdominal pain, diarrhea and headache, okay? And and the metoclopramide is causing the extrapyramidal symptoms, and the mosopride and etopride are just causing the prolongation of QT interval, thereby increasing risk of TTP, torsades de pointes, and arrhythmia. So this is what the prokinetics, and we have discussed PPIs, H2 blockers, and the antacids in our peptic ulcer section. You can refer to this videos for the great details there. So now we will go for the mechanism of PPIs. Right, there is a blockade of this pump. What is this? That is a proton potassium pump or proton potassium ATPases. We need to block this pump so that the acid output is inhibited. Second mechanism is the blockade of this receptor, that is the H2 receptor present over the parietal cells, right? So we need to block this receptor in order to decrease the acid output. And now we have discussed the mechanism of action of these two drugs. Now we will go for the indications and the uses of those two drugs here. So indications of PPIs is the peptic ulcers, bleeding peptic ulcers, and the GERD we have discussed, that is used in the GERD, and the Zollinger-Ellison syndrome, and the stress ulcers is there. Okay, and the indications of antihistamines are the H2 blockers are the peptic ulcers, bleeding stress ulcers, and the GERD, and the prophylaxis of aspiration pneumonia and urticaria and non-ulcer dyspepsia is there, right? So this is what the indications, followed by the side effects, right? And the cimetidine is causing the CNS, CVS, and endocrine side effects, and these include the headache, dizziness, hallucination, convulsions in the case of the CNS side effects. In the case of the CVS side effects, that is causing the bradycardian arrhythmia, right? And in the case of the endocrine side effects, that is causing the gynecomastia, impotence, and the loss of libido. So guys, everything was explained by me in the last section of peptic ulcers. You can refer for the great details, and now I'm just revising things with you guys, right? So guys, this is what the medications, and now we will go for the special points. Okay, so we need to provide the double dose. Okay, so we're just providing the 20 mg of omeprazole to the patient of peptic ulcer. Now we need to provide 40 mg of omeprazole to the patient of GERD. Okay, and we are just providing 40 mg to peptic ulcers, and we need to provide 80 mg of pantoprazole to the GERD patient. Okay, so double dose are to be given to the patient of GERD, and antacid can be included in the case of the patient of heartburn, right? And the prokinetic can be added along with the PPIs in order to provide the complete management of GERD. And we have given whole course of medication to the patient, but the patient is still refractory to the medication, then we will go for the surgery. That is one of the indications of surgery. So number one indication of surgery is the refractory to the treatment. Number two is if there is presence of any complication such as the Barrett's esophagus or the carcinoma esophagus, and whenever the patient is having any indication, then we will go for the further investigations before going for the surgery, and the investigations include the upper GI endoscopy plus biopsy, okay, to rule out any presence of the Barrett's esophagus or the malignancy, right? Second thing is the barium swallow to rule out this sliding hernia, right? The sliding hernia can be there, and we need to go for the 24-hour ambulatory pH monitoring to the patient, right? So this is what the indications, and now we will go for the fundoplication, that is a surgical management. Now we will discuss the types of fundoplications, and we have 5 types of that. Number one is a Watson. Okay, so in the case of fundoplication, what we are just doing is we are just wrapping the fundus over the esophagus and just covering the esophagus so that the reflux is not there. So reflux is being controlled by the wrapping of fundus over the esophagus, the lower end of esophagus, and this is what the fundoplication is. And we have the first thing, that is the Watson fundoplication, that is basically 90-degree anterior wrap of fundus over the esophagus, lower end of esophagus. So second thing is the Door, that is basically 180-degree wrap of fundus over the lower end of esophagus. And third one is the Toupet, that is basically 270-degree posterior wrap of fundus over the esophagus. And the Belsey Mark 4, that is 270-degree anterior wrap, just opposite to previous one, that is the 270-degree anterior wrap of fundus over the esophagus. Now we will go for the last one, that is the Nissel's fundoplication. We will go for 360-degree wrap of fundus over the entire circumference of esophagus. So this is what the Nissel's fundoplication, that is most common procedure done under the fundoplication, right? So this is what the fundoplication is. Now we will go for the surgery. We will go for the principles of fundoplication. So first principle is we need to go for the restoration of the intra-abdominal length of esophagus. So we need to go for the restoration of this length. Second thing is we need to go for tightening of this sclera, okay, so that the reflux is not there. Okay, so third one is the wrap of fundus. So this is the fundus. We need to wrap this fundus around the lower end of esophagus, and this is what the fundoplication procedure. And what are the complications of fundoplication? And we have two complications. Number one is the pneumothorax, that is most common intraoperative complication, and that is the gas bloat syndrome, that is the most common post-operative, that is post-operative complication here. Okay, that is post-operative complication of the fundoplication. So pneumothorax is the most common intraoperative complication, and since we're just going for the laparoscopic procedure, and the fundoplication is a laparoscopic procedure, and the air in the abdomen is just leaking from the abdomen to the thorax, and that is causing the pneumothorax here. Okay, so this is what the pneumothorax occurring intraoperatively. And second one, we will go for the gas bloat syndrome, right? And as we all know that the fundus is being wrapped around the esophagus, the lower end of esophagus, and when this wrapping is so tightened as the patient can't burp, cannot pass the air from mouth, and that is causing the bloating to the patient, and that is causing the epigastric pain to the patient, and this is what the gas bloat syndrome is. So what is the management of this condition? Since the fundus is wrapped so tightly as a patient can't burp, then we will go for the loosening. Then we're just making the lower esophageal sphincter, the wrapping around this, so loose as a patient's symptoms are resolved, right? So we will go for the partial wrap or the floppy Nissel's fundoplication, right? So that the tightened wrapping is being loosened, right? So this is what the complications of fundoplication, and thank you for watching.
So as always, if you're just having any doubt and query, you can go for the comment section below, hit the like button for the sake of the integration, and don't forget to subscribe. Pressing the bell icon will give me some vibe. So guys, we will meet at the another section of disease, which is my personal favorite, that is the inflammatory bowel disease. So till then, keep integrating. Thank you.